I have the pleasure to present our results from active surveillance of cutaneous leishmaniasis in Central Tunisia between 2009 and 2015. As background, cutaneous leishmaniasis is a parasitic vector-borne disease common in tropical and subtropical regions, including North Africa and Tunisia. And cutaneous leishmaniasis, zoonotic cutaneous leishmaniasis is the most frequent form in Tunisia. And its cycle of transmission is very complex. It results from the interaction between the rodent reservoir that are Psammomis and Obesis and Meriones shawi. And the vector is Phlebotomus papatazi female, and it is transmitted to a human by the bite of these phlebotomies. And the active lesion is look like this in children, and mainly with treatment, the disease leads to a permanent scare that is very disgracious, mainly when it's in the face. And all these hosts, the interaction, are influenced by climatic and environmental conditions such as temperature, rainfall, and humidity. The distribution of the disease worldwide, endemic regions or the main foci are located in the North Africa, mainly Tunisia, Algeria, Morocco, and the Middle East, as shown here, and also in the south of Europe, in Italy, the south of France, and mainly in Spain. In Tunisia, the disease is endemic in the center and the south of the country, and the governorate of Sidi Bouzid notify 40% of all notified cases in the country. Regarding the surveillance of the disease is notified within the passive detection as a disease of mandatory notification, but we know that passive detection of communicable diseases in general suffers from severe underreporting, mainly in developing countries. And our active surveillance was part of a whole project financed by the CRDE, is the Center of Research for Development based in Canada. And it's a whole project to improve the understanding of the various interacting climatic, ecological, epidemiological, agricultural, and also socio-economic factors that are lead to the disease. The objectives of our study were to study the relationship between climate and environmental conditions and the transmission of the disease in order to implement an early warning system based on these parameters, and also to measure the frequency of the disease throughout this surveillance, active surveillance, in order to assess completeness of the passive one. As the methods, we have here the study area. The first picture is the location of Tunisian within the Mediterranean basin. And the second is the location of the governorate of Sidi Bouzid in the center of Tunisia. And the third one is the 10 districts where we implemented this active surveillance with a population of about 34,000 people, and this region is characterized by a semi-arid climate. So we collected for active surveillance persons with active lesions or scare of the disease that occurred from July 2009 to June 2015, and for persons who live in this area. The monitoring was based in the notification of all people who came to primary healthcare facilities seeking for treatment, and the active research of other cases among their neighbors and families by the nursing staff. And also all schools were asked to seek for and to notify all new cases among students. Moreover, a community-based active surveillance were performed by the members of the research team, and the medical staff of healthcare facilities reviewed and ascertained cases notified in schools according to the lesion, clinical features of the lesion. Regarding data collection, we collect monthly and count monthly incidence of the disease in a standardized sheet according to the date of the lesion onset. And we also monitor climatic and environmental conditions. We collect the information on average, minimum, and maximum temperature, precipitation, wind speed, relative humidity, and also rodent density. We do laboratory diagnosis for a group of patients, not for all patients covered by the surveillance, by direct examination, skin culture, and also 2 methods of PCR. We also do 2 conferences, one on 2010 and another in 2013 for public healthcare facilities and for also the staff of the schools to raise their awareness of the importance to notify new cases to the system. And regarding statistical methods, we do analysis to identify the relationship between climatic conditions and the disease transmission by ARIMA, which is autoregressive integrated moving average. And also we do GAM, that is generalized additive model. As a result, this is the spatial distribution of cases by area of residence. And Skopje is reported most cases, then Hedia, and then Bir Badr. Regarding age and sex, most patients were assigned to 0 to 9 and 10 to 19 age groups. And for children, we have the majority were in males. Males were more affected, but in adults, females were more affected by the disease than males. This surveillance helped us to describe the cases by time, the epidemic curve based on monthly, the month of onset of the lesion. We showed seasonality of the disease. The most cases arose between August and January. And also we have demonstrated a peak on the last season, which is between July 2013 and June 2014. Comparing active surveillance to passive detections, we have results from all incidence rates from active surveillance were much higher than those from routine notification, and mainly for the total, we detect 3 times more cases than passive detections. And most cases, about 67% were detected by or were notified by primary healthcare centers, and only 25% by schools, and a few by the community-based surveillance. As a result of study of relationships between climate variables or parameters and the disease transmission, with ARIMA model, the disease transmissions were associated with mean temperature or average temperature with the same month, in the same month, maximum temperature in the same month, rainfall in the same month, rainfall 3 months ago, and average temperature 6 months ago, and rainfall 1 year ago, and the model have good R-square, which means that we have a good model to show this association. The estimation of expected number of cases by the ARIMA model shows that in red, this is observed cases, and in others, there is upper confidence level and lower confidence level. And also in this graph, we showed that the last season is also, we have a lot of cases. We have a peak of cases than what is expected from the confidence level. The results from the GAM model showed that the disease is related to mean temperature lagged for 4 months or 4 months ago, the mean density of rodents 2 months ago, and precipitations 1 month ago, and also relative humidity lagged for 4 months. And also in this model, we have introduced the season and the month, and we have we showed that the last season, the season 5, we have a peak. We have more cases than others, and the peaks also in months was October and November. And from this model, we have predicted, we make this model in 5 seasons, and we have predicted the number of cases for the 2nd or 6th season, and we have this graph. In blue, number of cases predicted by the model, and the area in blue is the upper confidence level and the lower confidence level, and the dots are the observed cases, because we have also results from our active surveillance, and here we think that we have well prediction of the number of cases. So, as a conclusion from our results, we conclude that there is an underreporting from passive detections, but we have also primary healthcare centers that notify most cases for active surveillance also. And we showed an association between zoonotic cutaneous leishmaniasis transmission and climate conditions. And as a recommendation, we have to improve passive surveillance, mainly to motivate primary healthcare staff by feedback information and awareness of the importance of this notification. And we think that at this stage, an early warning system is a feasible application for zoonotic cutaneous leishmaniasis, but we need a long time series, and we need also appropriate functional form and appropriate approach for modeling the disease transmission. And thank you.
Thank you, Hedia. Are there any questions from the audience? Nada.
Thank you very much for this beautiful presentation. My question, among your cases of leishmaniasis, what is the proportion of cutaneous versus visceral, or are they all cutaneous?
In this region, only cutaneous. We have 90% of zoonotic cutaneous due to leishmania major, and 10% of chronic cutaneous leishmaniasis due to leishmania kiliki, but not visceral. We have visceral is in the north, and a few in center in Korwan, but not in this region.
That's Mike.
Hello. Thank you again. Nice presentation. Really impressive, the model at the end. I noticed that in your model, one of the things you asked about was wind speed. And I just wondered what the thinking was there. Is it something to do with the mosquitoes being blown away? Or?
Yes.
Yeah.
Yes, the vector is a sandfly, but not a mosquito, and he can't fly, but by the wind, he go to the population with the wind, with the direction of the wind. And so we monitor also wind speed and wind direction, but they weren't associated to the disease transmission.
Right.
In this case, we introduce this variable, but they are not associated with the disease transmission.
Okay, that's really interesting. And so presumably with your model, you can predict on the basis of the climate conditions as you get into October, November, how large you might expect the number of cases to be. So if you see particular rainfall 2 months before, you may predict large numbers and be able to warn clinical services. Yes.
Yes, the main precipitation quantity are high in September, 1 month before the peak.
Yeah.
And also there is a large implication of temperature, rainfall, humidity, and all these conditions work together to make conditions favorable to the transmission of the disease.
Thank you.
Thank you very much. Very impressive presentation. I have observed in the age distribution that is affecting mainly children, and I wonder if if you can explain this, it's because the more adult population has been already exposed before, and they have some immunity, or how does it work? And then also about the feedback, for the same reason, how do you address specifically those ages, or the schools, the teachers? How do you increase awareness in that population?
Yes, in the whole project, they are actively involved in the project. And so for healthcare facilities and for schools, they are involved in the project and they notify. The healthcare facilities are also involved in the passive notification, but they notify less cases than our project, because they are motivated, they are involved in the project. We have a lot of feedback. We do a lot of conference to raise their awareness. We also responsible them and we involve them in all our actions. That's why they are more implicated with us, with the active, than with the notification. But if the health system or the health authorities will involve them, and if they give them also feedback information in their notification on all mandatory diseases and not only leishmaniasis. I think that they will be more active and notify more the cases to health authorities. In children, because of the immunity first, and because also of the exposure. Because we see in adults, women are females are more vulnerable because they are exposed in animal shelter. They do farming or agriculture activities, and they always have the children with there. And it's for immunity because they have not immunity, and also because they are exposed to the sandfly bites.
I think there are no other questions, so I want to ask one. Okay. With this, you said that you catch so many cases with active surveillance. So I wonder are you planning to continue active surveillance, or will you continue with passive surveillance only? And are you planning to do a re-evaluation after your feedback to family physicians and health centers? And my second question is, how do you plan to use this data for early warning purposes? I mean, humidity, temperature, and what will you do with this data?
Okay. First, for the first question, now the active surveillance is still going on only for the project to implement the early warning system, because we need more long-time series and then to do model and to validate the model. And for the passive one is still ongoing, but we think we have recommend to the healthcare authorities to give feedback for healthcare for the staff of healthcare facilities, primary healthcare facilities, on all notifiable disease to enhance the notification and to give them the information and about the useful of their notification, to motivate them to do well and to notify more cases. And for the second question, we still going the surveillance, and we hope that we will have data for 10 years, and we projected to do the model on 70% of the data and then validate on 30%. So that we have all observed cases, and we will study the relationship between these conditions and show which variables are more implicated in the transmission of the disease. And then we will use these variables with coefficients to predict the number of cases in 30% of the data, and then to compare and to assess the fit between the two, the observed and the predicted ones.
So you're just planning to compare these to surveillance, I mean, for surveillance purposes. I mean, if you are implementing an early warning system to predict cases, maybe you could consider about drug resistance and transmission ways. I don't know what transmission cycle is in your country, because they are different, as you know.
Yes.
And the interventions also differ by this, so maybe you could consider this too.
Yes, the useful of the early warning system, because we have no effective control measures on the disease, and the population is a rural population with mainly farming activities, and they do not stop their activities to protect themselves from the disease. So if we predict that the next season or the next 6 months will be an epidemic, we can implement control measures, especially for this period, short period, not to tackle or to eradicate the disease, but to diminish the magnitude of the number of cases.
I think there are no questions. Thank you very much for your presentation.